It's my pleasure to now introduce nurse practitioner Joanna Davis. Joanna completed her bachelor's in human kinetics in 2008 and bachelor's of science in nursing in 2010 and master's degree in nursing in 2015, all at the University of British Columbia. As the nurse practitioner, Joanna is an integral member of the Pacific Parkinson's Research Movement Disorders Clinic team. Joanna, welcome. Thank you so much for joining us this morning. I'll pass it over to you now.
Great, thanks, Alana. And welcome everybody to day 2 of the Parkinson's disease new diagnosis workshop. As Alana mentioned, I'm Joanna Davis and I'm the nurse practitioner at the clinic at UBC. So just before I begin, I want to acknowledge that the land on which we gather is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So in last week's discussion, Dr. Squires would have gone over what is Parkinson's, reviewing the motor and non-motor symptoms. And so today we'll be building on that knowledge to review more of the management side of things. We'll review the medications, some alternative therapies, advanced therapies, treatment of non-motor symptoms, and then have some time at the end for some questions. So thank you all for joining today. The aim for this presentation is really to build your knowledge on Parkinson's disease so that you can work with your care team to be a really integral member of that care team and make informed decisions. I really hope that you find it informative today and hopefully leave with some practical tips that can help your day-to-day. So getting right into it, management of Parkinson's treatment is not just with medications. So there's a really large emphasis on physical therapy and exercise, and we'll dedicate the entire next session to that. I won't get into it too much today. However, there is great treatment for the motor symptoms of Parkinson's and the treatment of non-motor symptoms, which is what we will discuss today. Just briefly on exercise, if there's one takeaway from this new diagnosis workshop, it's that exercise is very, very important in helping slow the progression of disease. The benefits of exercise can also have profound effects on many of the non-motor symptoms of Parkinson's, including fatigue, anxiety, depression, sleep, so improving daytime fatigue and improving sleep onset and sleep duration at night as well. There's not one particular exercise that we recommend, but rather finding something that you enjoy doing and that you can stick with. Generally speaking, we recommend 30 minutes of moderate activity about 5 days per week. There have been some great research around boxing and Tai Chi and yoga, and that's all regarding incorporating those large movements that we know are really good for exercise. And as I mentioned, Michelle will go over all of this next week. So the first question we get generally in clinic is, when should I start medication? And now this is really an individualized approach and based on the severity of symptoms and also if there are any functional limitations from the motor symptoms. So not everyone will start treatment at the time of diagnosis. Rather, some people might wish to do more of a vigorous physical exercise or physical therapy and then wait a few months to see how their symptoms evolve. Medications are really there to help manage the symptoms so that you can live your carry out your daily activities and live a good quality life. So even if the symptoms are quite mild, you have to reflect on how those symptoms are affecting you. Some patients may say that, they have the tremor is quite mild and not bothering them. When we delve deep into how they're doing on a day-to-day basis, they're telling us that, I'm having more difficulty with typing in my job, or I haven't been going out with my friends or socializing because of the tremor. And that might be the time to start thinking about medications. Another example might be when someone has been doing a really good job at exercise and something that we really encourage, but now they're having more rigidity or they're having more stiffness in their arm or their leg, and that's interfering with their ability to go out for that run or go out for that walk. And so again, that's the time when we might start thinking about medication. So there are a number of different medications that we use in Parkinson's disease. The first one that we'll be reviewing is Levodopal Carbidopa. Many of you may have already heard of this or maybe are already taking this medication. Now, this is really the gold standard therapy for Parkinson's. It's been around for a very long time, and it's the best medication to help the motor symptoms of Parkinson's. So levodopa is more commonly known as Sinemet, and it comes in two formulations. So the picture shown here is the yellow. That's the quick immediate release medication. There also comes in a formulation which is a controlled release or long-acting medication, and that's pink or brown in color. So there are two components to this medication. The levodopa is the active ingredient that is converted to dopamine in the brain. Carbidopa prevents the conversion of dopamine outside of the brain to help with side effects, to prevent side effects, which we'll discuss. So if you were to take levodopa without the carbidopa, a lot of it would actually get broken down in the gut, and less of it would actually reach the brain. And a question we get quite often is, does levodopa slow the progression of disease? And it doesn't. However, we use the medication because it allows you to carry out those daily activities and do that exercise, because we know that staying active can really help slow the progression of disease. So how is it given and what are the side effects? So we introduce levodopa slowly over weeks and months to help minimize those side effects. The side effects that we see are generally nausea, low blood pressure, headache, maybe feeling a little bit dizzy because of the blood pressure dropping. And these side effects are usually transient, meaning they go away after the body gets used to them. They can also be minimized by taking them with a light carbohydrate snack, such as a cracker, toast, or fruit. And if side effects are more prominent, then we can sometimes use another medication to help offset those side effects. So another very common question we get is, I've heard I should take it away from food or protein. Is that true? Now, the pharmacist will tell you, and you'll see on the information package in the prescriptions, that to take it on an empty stomach and away from protein-rich foods. And the theory behind this is that the levodopa is absorbed in the small intestine, and when protein molecules are broken down into amino acids, they're also absorbed in the small intestine, and they compete for action, so to speak. So during the initial stages of the disease, this is not all that important. And only about 20 to 30% of people with Parkinson's have some sensitivity to protein, meaning that they notice that their medications don't work as well when they take it with food. That being said, we don't often make a fuss in the earlier stages of the disease because we know that the patient's still getting a really good response to the medication. And I also find that it's stressful in itself, getting a diagnosis of Parkinson's and now taking medications, up to 3 times a day. And taking it with food can sometimes improve compliance. It can improve the ability to remember to take your medications if you're taking it at meal times. So what does levodopa actually help with? If we go back to the basics of what Parkinson's is, and remember that dopamine is the neurotransmitter that's responsible for coordinating movements in our bodies, in those with Parkinson's, there is a loss of that dopamine. And so we are essentially giving you that synthetic form of dopamine. And levodopa is really there to help manage those symptoms, so the motor symptoms. So symptoms that generally tend to improve are tremor, bradykinesia, or that slowness of movement, and rigidity, or the stiffness that people experience. Now, it can also have an impact on non-motor symptoms. So these are things like with the upper gastrointestinal system, so drooling or dysphagia or difficulty swallowing, pain, sweating, episodic anxiety, which is anxiety that comes and goes throughout the day, and fatigue. When symptoms improve, we call that levodopa responsive, meaning you've had a good response to the levodopa, and that will often help further strengthen the diagnosis. So what if it feels like the medication isn't working? If someone has started on a dose and it's 3 to 6 months in and they don't really notice the medication working that well, it's important to bring that up with the movement disorder specialist, because sometimes we just need a little bit more dopamine to fill that tank to relieve those symptoms. And at this time, they might also inquire about bowels, which we'll speak about, any food. Maybe someone is sensitive to food, or there is other interference in the gut, such as a bacteria that can occur. So terminology to know, and Dr. Squires may have gone over this last time, but it is really important that patients and their caregivers understand these terms because we will use them often whenever we have a clinic visit. So the term on is when medications are working and symptoms improve. Off is when medications stop working, and that's when the symptoms are present. Kicking in, so many people will feel the medications kicking in after about between 15 and 60 minutes. And wearing off is when medication starts to wane right before the next dose. And dyskinesia are these rocking, writhing movements that we see. So the therapeutic window. So a question that we get quite often is, I don't feel the medication kick in or wear off. Does that mean it isn't working? And the answer really is no. Sometimes people can't feel every tablet that works. Some people can't feel every tablet, and this is really normal during the early stages of the disease. As you can see in the diagram here, the therapeutic window is actually quite wide. And so you take a dose of the medication and you get some symptom relief that generally lasts until your next dose. And this is called a long duration response. Overall, someone taking levodopa will feel better, but they may not actually notice if they miss one dose or delay one dose by an hour or so. On the other hand, if you were to go off of the medication completely, which we definitely don't recommend doing without being under some sort of supervision for that, after a few days, the symptoms would arise again, and you would feel those. So dyskinesia are unintentional involuntary movements, rocking, writhing, sometimes people refer to them as dancing movements. Not everyone will experience these, and the current understanding is really that dyskinesia correlate best with longer disease duration and higher individual doses, as opposed to a cumulative exposure to levodopa. So people who are diagnosed at a younger age may be, not everyone, but may be more vulnerable to developing them simply because they will have had the disease for longer, whereas someone diagnosed when they're older may only have the disease for 10 to 20 years. It's really important to note that dyskinesia can range from very mild to more severe. And oftentimes people experiencing the dyskinesias prefer to be a little bit dyskinetic, because when you're in that state, the other symptoms of Parkinson's, like the stiffness and tremor, are relatively controlled. Now, from an outsider's perspective, it can look uncomfortable for the patient, but the patient that's experienced them doesn't often report that. So another question we get quite often is, should they delay starting levodopa because they've heard that there's only a few good years of levodopa therapy? Now, there's actually no evidence to support the benefits of delaying levodopa treatment. Levodopa and other medications never really stopped working. As you can see here, the therapeutic window gets narrower as the disease slowly progresses. However, this is due to changes in the brain and the reuptake of the dopamine that is affected. So it's really important to note that fluctuations may occur, within 5 to 10 years, but it can be well managed by tweaking the medications and adjusting them a little bit here and there. So just a little bit about wearing off and making the most out of on time. So if you start to experience some wearing off, meaning your symptoms start wearing off an hour or half an hour before the next dose, then it's important to bring that up with your movement disorder specialist or care team. After the disease progresses slowly, the therapeutic window gets narrower, as I mentioned, and we expect this within 5 to 10 years. If someone is having more symptoms kind of half an hour or an hour before the dose, then this is when we might either add on another medication or adjust the timing. So you would take the medication a little bit more frequently. So other medications that we use in Parkinson's, one of them is the monoamine oxidase type B inhibitor. And this, you may have heard of selegiline or rasagiline or Azilect. And these work a little bit differently. They work by blocking the enzyme that breaks down dopamine. These are usually used in early disease as monotherapy or kind of the first line therapy that people might try, or in addition to levodopa to improve on time. It's generally well tolerated with minimal side effects, although it can cause some insomnia if taken later in the day. Dopamine agonists work by stimulating dopamine receptors in the brain. So they kind of mimics dopamine in the brain. Now, the side effect, or these medications are pramipexole, ropinirole, rotigotine, which actually comes in a patch form. And the side effects, such as impulse control disorder, are generally seen with higher doses. And not everyone would be at risk for developing them, as it is quite multifactorial. Those that are more susceptible may be males that were diagnosed at a younger age. And so impulse control disorder is the act of impulsive shopping or gambling or hypersexuality. It's associated with changes in posture, and it can cause some sleep attacks, which are rare. Now, the medication can be used in conjunction with levodopa, and this can sometimes help patients who are experiencing dystonia or that pain, that painful cramping that people experience. The patch may also be a good option for somebody that is not keen on taking more medications orally. So you apply the patch once a day and exchange it every 24 hours. Now, Amantadine is another medication which we use more often to treat dyskinesias. It is well tolerated. It can be used early on for very mild symptoms, and it works a little bit differently by blocking glutamate and NMDA receptors. The side effect profile is livido reticularis, or it's kind of like a fishnet cosmetic rash that people can get on their leg. And it is solely cosmetic, so it actually doesn't cause any problems, but it is there. And it does go away after the medication has been stopped. It should be used in caution in elderly patients, as it can contribute to hallucinations and cognitive concerns. And COMT inhibitors. So this is a very long word for catecholamine methylase transferase inhibitor. And the brand name is COMT. We use this medication when people are experiencing wearing off. And it helps prolong the dose of levodopa by slowing down the breakdown of dopamine in the body. It's quite well tolerated. Initial side effects are mainly nausea, so I really recommend people to take it with a carbohydrate or take it with a snack that can help minimize that. It can cause some loose stool, which in the Parkinson's population is sometimes not that bad because we know that constipation is a bit of an issue. It can also cause orange-colored urine, so just something to be aware of that, that might happen. So alternative therapies. So as far as alternative therapies go, mucuna pruriens is a natural substance that comes from a legume. It's the velvet bean that's found in tropical and subtropical climates. And it comes in an extract and pill form that can be bought at health food stores without a prescription. Now, it's really important to note that this medication is not actually manufactured and approved by Health Canada. So the evidence against it is limited in that we can't really recommend it, but it is there if people do want to try it. It's hard to know exactly how much is in each capsule and what the exact quantities are. So studies have looked at how much levodopa is in each capsule, and it's there's a wide variety of, it varies widely and is quite unreliable. As well, when we give levodopa in the pill form, remember that we're giving it with carbidopa to help minimize the breakdown outside of the brain. So mucuna, because it's not given with carbidopa, you'd have to give a much higher dose in order for it to get across the brain and provide that symptom benefit. So supplements and diet, there's a huge market for supplements, and it may be really hard to navigate, which ones to try or what the evidence is. So unfortunately, there's little evidence to support the use of antioxidants and supplements in slowing the neurodegeneration of or improving symptoms in Parkinson's. There have been some studies that have looked at CoQ10, vitamin D, tocopherol, glutathione. However, they were mainly clinical studies with smaller sample sizes or were done on animal models. Similarly, antioxidants such as those that contain vitamin E showed little benefit in comparison to placebo. There may be some benefit to taking vitamin B12 in patients who have been on levodopa therapy for a very long time, as well as we know that in the aging population, it can be more difficult to absorb vitamin B12. So this is something that you could get tested through your family doctor or nurse practitioner to check for any deficiencies there. Now, as for diet, there's not one particular diet that we recommend in Parkinson's. We can really recommend is a nutrient-dense diet from all the food groups, very colorful vegetables, whole grains, healthy proteins, and fat that give us the essential micro and macronutrients that our bodies need as we age, and maintaining that muscle mass is very important. There's been some research around looking at the MIND diet, the Mediterranean DASH diet, and that it may be associated with slower progression of Parkinson's, although more research is really needed to confirm that. And lastly, there's some great research going on at UBC looking at the gut microbiome connection and the potential for probiotics to help prevent and slow the progression of disease. So cannabis, another very hot topic. This is a really interesting field. And as many of you know, medical marijuana is widely available in Canada. But the current understanding is that there's insufficient evidence to recommend the safe use of cannabis for motor symptoms in Parkinson's. Well-designed randomized controlled trials really are needed to better establish the evidence. There are some anecdotal reports that cannabis can help with non-motor symptoms. So these are things like sleep and pain, anxiety. It can increase appetite. So it may be good for someone that's experienced a lot of weight loss. I think it really is important that people know the risk before you try it. Potency of marijuana has really increased dramatically in the last 30 years. So someone who has had a few puffs, 40 years ago in the backyard, it's quite strong now. And it can cause certain things in the body, like slowness of thinking, balance issues, paranoid thoughts can be potentially exacerbated. And especially with higher THC content, which is causes the psychoactive effect. I'd always recommend ensuring a safe use in a safe environment if you did want to try it. Now, advanced therapies are available. So Duodopa is a levodopa gel intestinal infusion, and this requires a surgery to be placed in the jejunum, the small intestine. The people must meet criteria for it, so spend more than 25% in an off state and have motor fluctuations. Again, it only works for someone that's responsive to levodopa. And have tried many of the other different therapies that are out there. Deep brain stimulation is another advanced therapy, and this works so it's a brain surgery where little holes are made in the brain, and then an electrode goes through, and it helps to smooth out the motor fluctuations by electrically stimulating a certain part of the brain, which is in the subthalamic nucleus or the globus pallidus or the thalamus. And that can really help reduce tremor as well. Symptoms, again, that respond are symptoms that are levodopa responsive. And it's important to note that it doesn't fix all problems. So it doesn't work on some of the non-motor symptoms of Parkinson's, and it doesn't work on, freezing of gait or some of the other issues that we see. So shifting gears a little bit, you learned last week that non-motor symptoms are very common in Parkinson's. And given the time constraints of this talk, we can only review kind of the more common ones that we see. It's important to note that many of these issues can be dealt with by the family doctor or nurse practitioner, so it's important to include them in your care as well. Um, and these motor symptoms can really be well managed if you follow the right treatment plan and under the right guidance. So constipation, as Dr. Squires would have gone over last week, is very, very common. Some studies report that over 70% of people with Parkinson's experience some constipation at some point in their illness trajectory. And this is something that is reported to me every day in the clinic. So, and why is it important? Constipation can be uncomfortable. It can make you feel bloated or nauseous. It can cause abdominal cramping, but it also can affect the way your medication is absorbed. Because it's absorbed in the small intestine. If you're very backed up with stool, then that medication is not being very well absorbed, and therefore your symptoms aren't that well relieved. So following kind of a natural approach, increasing fiber-rich foods in the diet is very important, aiming for about 30 grams a day. These are things like whole grains, oatmeal, flax, hemp hearts, psyllium husk, fruit, bulk vegetables like broccoli and cauliflower, and then natural laxatives. So the fruit that contains sorbitol can help get things going a little bit. And these are things like prunes and apples and pears, with the skin on. If you're increasing fiber, it's very important to increase your fluid to help push things along. So increasing fluids and increasing activity and less sitting can help. And then if it doesn't improve with that, then we always look to, we turn to over-the-counter laxatives. One that we use quite often is polyethylene glycol or PEG, and this is found in Restorelax or Laxaday. And this is actually very gentle on the system and can be taken quite regularly every day or every other day if needed. So managing bladder issues or nocturia, which is voiding or urinating at night. So this can also be related to other non-Parkinson's issues, like an enlarged prostate for the males in the audience. So it's always important to follow up with your family doctor or family practitioner. Lifestyle modifications can help, so less water in the evening time, limiting caffeine and alcohol in the evening and afternoon, pelvic floor physiotherapy, so really strengthening that bladder, the bladder muscles, exercise and bladder training. We can refer to a urologist. And then there are some medications that can have anticholinergic effects, which can potentially increase, confusion and dry mouth and put some people at risk for falling. But there are certain medications that we can use safely. And this is one called mirabegron that we use quite frequently. So managing orthostatic hypotension, and it's actually neurogenic orthostatic hypotension, which is a very fancy word for blood pressure dropping when you go from sitting to standing. And the symptom of this is that you feel dizzy or lightheaded. Now, we worry about low blood pressure in Parkinson's. And this is, so one thing that we can recommend is changing positions slowly. So sitting at the edge of the bed, if you're laying down and then you sit up at the edge of the bed and wait for a minute or two before you stand up. Or if you're sitting for a long time at a restaurant, get some, move your legs a little bit, get that blood pumping in your legs and then stand up. You can also try increasing sodium and fluids in your diet, which increases the intravascular volume, thereby increasing blood pressure. The compression socks can also be helpful in preventing that pooling that we see in the legs. They can be a little bit difficult to put on, so using a cotton glove and then pulling them up can be helpful. Also using an abdominal binder can help with that. And then preventing Valsalva maneuvers or straining is also important. And then there are also medications that can help increase intravascular volume, thereby raising your blood pressure. It's really important to speak to your care provider, as these medications can cause an increase in supine hypertension. So can increase the blood pressure when you lay down. So it's important to bring this up with your family doctor. So as Dr. Squires went over last week, anxiety is a very, very common symptom of Parkinson's. Not everyone will feel anxious, but some people will. When we feel anxious, we naturally feel quite tense or shaky, and that can actually heighten many of the motor symptoms of Parkinson's. Anxiety can make tremor worse, it can make freezing of gait worse, which in turn can make the anxiety worse. It can also affect our sleep and make it more difficult to fall asleep at night. So if anxiety is what we call dose specific, as discussed earlier, meaning you're only getting anxiety during periods of wearing off of medication, then sometimes a dose adjustment can help. Vigorous exercise has been shown to have calming effects on the body after working out. And then psychotherapy, so cognitive behavioral therapy, is an evidence-based treatment for anxiety. And this has been really well studied and is one of the first-line non-pharmacological treatments for anxiety in the general population. And more research is needed in the Parkinson's population, but we do know that it works for people that don't have Parkinson's. When someone is in the moment and feeling very anxious, their heart is beating, they're feeling flushed, hot, clammy, and dizzy, then that's when, some mindfulness meditation or deep breathing can help. And then there are always medications. So for people who are worrying endlessly or ruminating and thinking over and over again about certain things and are not coping with the anxiety, then a class of medication called the selective serotonin reuptake inhibitors can really help. These are things like citalopram or sertraline, and then there's also another class of medication, which is mirtazapine, and this can be quite beneficial in patients with Parkinson's. The side effect is that we give it before bed, and so it can cause some sedation. It can help with that sleep onset. It can increase appetite. So for those that are experiencing weight loss, it can help with that. And then there are also benzodiazepines, which are generally used or kind of reserved for panic attacks or that acute anxiety that people experience. And generally speaking, we try to avoid these in Parkinson's because there are concerns around balance and falls risk and cognition issues and dependency. So just a little bit about cognitive behavioral therapy. So although more research is needed, I do see people in the clinic that have tried this and have gone through it over 6 to 10 weeks, and it has really helped. So it's really how this slide kind of shows how CBT works. It works by targeting the negative thought patterns that affect our behavior. And often it includes some exposure therapy. So it targets that avoidance behavior that we see. So the thought is that everyone will notice my tremor or my stiffness. Therefore, I feel very self-conscious or nervous, and then I might withdraw from others. So again, this is offered by a trained CBT, someone who is trained in CBT. There are also workbooks and some apps that are available. So managing depression. So similarly, depression can be very common. And a lot of the treatments for anxiety can also be used for depression. There's a really high correlation between insomnia and depression. When we're feeling sleep deprived, our mood is lower. And so we may feel more irritable or have more apathy or more lack of motivation the next day. And so the strategies for this are improving sleep. So, that can thereby improve our depression as well. Apathy or the lack of motivation can sometimes improve by incorporating daily schedules of an activity or socializing or trying to get out of the house. There's talk therapy, so connecting with one of the amazing counselors at Parkinson Society, physical activity, and then antidepressants as well. So just some resources for anxiety. We know that mood conditions of the non-motor symptoms are really the #1 predictor of quality of life. So I think it really is important to bring this up with your care team if you're feeling low or if you're feeling anxious, because there is great management for it. And these are just some resources that are available, which might help. So managing insomnia, sleep problems in Parkinson's can be related to many, many different things, and it isn't usually just one problem. So it's really important to bring this up with your movement disorder team, as they can help identify what may be the root cause. And because the answer is not always medications. So sleep hygiene is a term we use to describe positive sleep habits to set yourself up for a good night's sleep. So these are things like getting enough exercise during the day, having exposure to sunlight or to help that circadian rhythm, limiting naps during the day, reducing screen time before bed, keeping room for sleep and sexual activity only, so no electronics in the room, and then trying to incorporate some relaxing strategies before bed. Oftentimes, someone might fall asleep easily, but then wake up due to stiffness or being very uncomfortable or difficulty with rolling over in bed overnight. Or you wake up to void. So if discomfort is the issue, then sometimes we might use a dopaminergic medication, so a long-acting levodopa, which can help with those overnight symptoms. And then if you wake up in the middle of the night because you're feeling very anxious, then the research is really telling us to do some deep breathing in bed. If after 15 minutes you can't fall asleep, get up, go to another dimly lit room, do something boring like read through a boring magazine or read a book, nothing stimulating, so don't clean, no electronics, do some deep breathing, and then try to go back to bed. And the thought behind that is to really try to create a positive sleep association between your bed and a place where you fall asleep and not just lay there awake and anxious. And then if there is any sort of mood involvement, then we can use some sedating medications or a sedating antidepressant or anti-anxiety medication. So managing REM sleep behavior disorder. So treatment for this, and if you remember, this is when you act out your dreams or have very vivid dreams. And the treatment is not always necessary unless there is a potential for harm. And remember, the person with Parkinson's may not actually know that they're having those very, vivid dreams or know that they're yelling in their sleep. And so the bed partner is important to bring that up. And, if they are getting an elbow in the side of the body, then that's important for us to know. So ensuring a safe bedroom environment, so decluttering, putting pillows between the partner, moving the nightstand away. And then as for treatment, melatonin can help and can be effective, starting at higher doses, kind of 3 milligrams. For more severe cases, we use something called clonazepam, which is a benzodiazepine, but this also has sedating properties. So any help with, it can help with sleep initiation as well. Of course, it is important to use clonazepam in caution, as it can cause clumsiness in the morning, increased risk for falls. And just before we kind of wrap up here, it's important to know that it's not always Parkinson's. So we expect a very slow and gradual progression of the disease. And of course, some days might be a little bit worse than others based on how well you slept, stressors in your life, your diet, your bowels, your mood. But if you notice a rapid decline or change in symptoms, then it's really important that we rule out other causes. So sometimes things like a respiratory infection or a GI bug or a bladder infection can appear to make symptoms worse. And so it's always important to bring that up with your care provider. And then if everything has been ruled out, then bring it up with your movement disorder specialist as well. So the key takeaways, so while receiving a diagnosis of Parkinson's may seem really overwhelming, I want you to really leave today hopeful that you can live an active and healthy lifestyle with the help of medications and exercises and resources to support you. And I want to really thank you all for joining today's discussion. And I think we have some time for questions. I'm not sure what time. We have about 10 minutes, I think.
We have one raised hand. Maybe we can take that one first, Joanna.
Sure. How do I, attendees, okay, here.
So
Do I just put chat?
yes, you can click on chat. So Peggy, go ahead. You'll have to unmute yourself.
Hi, Peggy.
I didn't have a question. I probably raised my hand when we started, but I've enjoyed your presentation, and I'll listen to any other questions that might be asked. Thank you.
Okay. I'll just go through some of these questions here. The slides from the presentation will be available, I believe. One medication is, how do we get carbidopa added to our medication? So yeah, it's a good question. Maybe I didn't explain that clearly. So the Levodopa Carbidopa is actually one medication. So it's in one pill form. So you don't have to take another pill on top of the Levodopa, if that answers your question. If someone's having lots of nausea, sometimes we can add a little bit more carbidopa. So you can get carbidopa in a separate pill form, but generally we give it all in one pill. Our supplements. Is swimming good exercise for dealing with Parkinson's? Yeah, so I think Michelle will probably go over this a little bit more next week, but really, swimming can certainly be really good for Parkinson's. It's a low impact exercise. It incorporates a lot of those large amplitude exercises that we really encourage. So making yourself really big can be really beneficial. So with that swimming, doing that front stroke or breaststroke can certainly be beneficial. I'm not sure of any particular studies that looks at that, but certainly it would be great if you did that. A few questions on CBD oil. So similarly, that unfortunately, there's not a lot of research to support its use in Parkinson's. There have been very small case report studies and anecdotal reports that CBD oil and CBD can help with some of the non-motor symptoms. And so, CBD oil, it's also sometimes hard to know exactly what's in it or what the strength is, ensuring that there is no THC if we don't want those psychoactive properties in it. So that's kind of around CBD. So any suggestions for muscle cramping or muscle fatigue while exercising? Yeah, so, sometimes the muscle cramping and the muscle fatigue can be off symptoms. So when the levodopa dose is kind of waning a little bit, that's when some people can experience those symptoms. And so sometimes, obviously speak with your movement disorder specialist or your care team, because sometimes taking a little bit of extra levodopa might help right before you go and exercise. And just generally speaking, if you overdo it, sometimes that will cause more muscle cramping or muscle fatigue. So, doing everything obviously in moderation. You mentioned low blood pressure is common. If a patient is on blood pressure medications and has just received a new diagnosis, how often should they monitor their blood pressure? Yeah, that's a really good question. And it's probably very individual. It's based on, how many blood pressure medications you're on and what your baseline blood pressure is. So I'd probably recommend asking that to your family doctor, your cardiologist. But generally speaking, so yeah, we worry about low blood pressure in Parkinson's, and oftentimes patients who have been on blood pressure medications for years to control the hypertension, Parkinson's and being on levodopa can bring down the blood pressure naturally. So sometimes we, will work with the family doctor to reduce that blood pressure medication. And sometimes even patients will certainly come off of it. What are the signs of levodopa overdosing? So there's not, again, the doses of levodopa are very individualized based on the severity of the symptoms. So there's not really, I guess the overdosing would be if someone is having a lot of dyskinesia and they have experienced that, then they might have more kind of writhing movements, and then we might decrease the dose a little bit. If someone's not having any dyskinesia, you know, having too much levodopa can cause more headaches or cause a drop in blood pressure. So it's important to monitor that. Yes, I have taken magnesium once a day and it has helped with cramping in my leg. And yes, magnesium can help. Sometimes taking some magnesium glycinate or magnesium citrate before bed can help with sleeping as well, and providing that a bit more of a relaxed feeling. So much information to absorb. Yes, it can be very overwhelming, and I hope I didn't overwhelm you. I think it's also important to, and I think Michelle goes over this a little bit next time, but you know, where you can find reputable information on Parkinson's is important. Obviously, there's Dr. Google, who we don't recommend going to often because you can be kind of go down in a bit of a rabbit hole depending on where you're looking. So the writhing motion, what is a writhing motion? The writhing motion is the dyskinesia that I talked about. And that's kind of it kind of looks like this, kind of like the Michael J. Fox movements. If you Google it, you'll probably find someone with very severe dyskinesia, and that's not always the case. You know, sometimes it's very mild, just a little bit of rocking or a little bit of kind of the leg moving.
I think we have another raised hand.
Mm-hmm.
Let's see, Janice, did you want to ask your question? You'll have to unmute.
Can you hear me?
Yes.
Okay, I have a question. What are SSRIs? SSRIs.
So SSRIs are selective serotonin reuptake inhibitor. And I wouldn't worry too much about that. It's a mouthy amount of words. So this is a medication that we use for anxiety and depression in Parkinson's, and in patients who have anxiety and depression, and there are a few different ones that can help. So we know that in Parkinson's, there are changes in the brain, and you know, the loss of dopamine. There's also a similar, the serotonin receptors can also be affected in Parkinson's disease.
Okay, I had another question.
Mm-hmm.
You can talk now, Tom.
What?
You can ask them.
I have another question, and that is Parkinson's disease caused by lack of dopamine?
So what we see in Parkinson's is that there is a loss of dopamine. Excuse me. So by the time of diagnosis, when someone actually has symptoms of Parkinson's, like the tremor or stiffness, there's already been a loss of dopamine in the brain. So yes, that's why someone might have the symptoms of Parkinson's.
Okay,
because it's related to dopamine loss.
I got it.
That's not per se the cause of Parkinson's, however. The cause is, you know, somewhat unknown, right? There's perhaps a genetic component.
Okay,
to it as well.
I get it. Thank you. Okay.
Due to bladder action, so someone's having some bladder problems in the middle of the night and find that they can't get back to sleep again. So this is very, very common. And again, it begs the question of are you waking up to pee, or are you waking up and then because you're awake, you say, well, I might as well just go to the bathroom and relieve my bladder. because the treatment might be a little bit different. So sometimes bladder training can help overnight, and then sometimes medications can help with controlling the bladder overnight. Other practical tips, for men, they can use a urinal at the bedside. So instead of actually getting up to walk to the bathroom, sometimes using a urinal or, using something like that might help. But really, if you're having a lot of bladder activity in the middle of the night and you really can't get back to sleep, again, using that sleep hygiene. So, you go and void and you go to the bathroom, you urinate, you come back to bed, you try to do some of that deep breathing exercises and see if that helps you get back into that restful state. Are eating disorders common? I wake up to eat twice in the night. Now, I'm not sure if you are on any treatment for Parkinson's yet. There are some medications that can cause, that impulsive control. So as I mentioned, some of the dopamine agonists can cause that impulsivity, so impulsive eating, impulsive shopping. And so that's important to bring up. But eating disorders per se are not common in Parkinson's. If anything, I find that people who are sometimes very strict with their meal times, because now they're taking medications, 3 times a day, and they're really worried about that protein. And so that's why I said sometimes it causes more stress than benefit. And sometimes it's better just to eat the food and eat the meal, right? You need to have those nutrients. We see more weight loss in the Parkinson population. So it really is important to eat that good quality food. Another question about with or without food, what is actually recommended. So, as I mentioned, earlier on in the disease, the symptoms are mild and you're still getting a really good response to the levodopa or to the medication. So sometimes you don't actually have to take it on an empty stomach. When someone's starting medication, take it with some food or take it with a light carbohydrate snack, because it will help minimize that side effect. Someone said that they're ready to take medications. Not ready to take meds, but feel pressured to start. And I mean, who are you feeling pressured by? I hope that you don't feel pressured. It has to be really an individualized decision, because you're the one that's living with the Parkinson's. What we can try to recommend is that, through evidence-based research, we know that the medications can help minimize the symptoms of Parkinson's so that you can carry on with your daily activities. So perhaps that's why someone might be pressuring you, but it's up to you because you're the one that's living with it. Yes, the new Parkinson's disease treatment book, Dr. Ashlog, is really well done. So I would recommend that. Just have about 5 minutes here. There are a few that I want to leave until next week, because I think Dr. Squires would prefer to answer some of those ones. Are all supplements, so another question about supplements, are all supplements equal, or is price an indicator of quality? And I'm not sure about that exact question. As I mentioned, supplements are, there's not a lot of evidence to suggest that they are beneficial in Parkinson's. And yes, some of them can be quite expensive. So that might be a deterrent in itself. I'm just reading some of these other ones. What's out there for bladder at night for women? So mirabegron is a medication that I discussed that can also be used in males or females, and that can help with the urge incontinence or the increased urgency. When you really have to go, you have to go, or you increase frequency of urine. It's a bit of a catch-22 because I find that people with that experience a lot of bladder issues don't want to drink water. But it's really important to drink water because that will help with the bowels and help with relieving constipation. And so, I always recommend keeping a few water bottles around the house, maybe drinking more water when you're going to be home or when you're closer to a bathroom if you're worried about that. But it certainly is important to stay hydrated as well, which also has an effect on your blood pressure. Any other questions that I missed here?
There's one on Parkinson's and prostate cancer. Is that the one you're deferring to Dr. Squires?
Yes. I was going to defer that one to Dr. Squires next week. That's a good question. To simply answer your question, yes, Parkinson's can increase the frequency of urination as well. And then next week, there'll be another, the last discussion is next week with Michelle McCarthy, who's the physiotherapist. And so she'll be able to provide some great resources for you as well on that topic.
Okay, well, I think those are the end of our questions. Were there any more, Joanna, or is that it?
I don't, unless I missed them here. I think I went through them. CBD oil, I answered that one.
Some of them are being sent to you privately, so I don't see those ones, and then some are public.
Okay. Thank you. You're welcome, Kathleen. Yeah, I think that was it. And again, we'll have time next week. So, bring your questions, write them down. If you think of anything between now and next week, then we'll have time 30 or 40 minutes next week to answer those questions.
Well, thank you for sharing your expertise with us today, Joanna. And thank you all for attending. And I look forward to having you all attend the last talk in the new diagnosis workshop series. As Joanna mentioned, it will be neurophysiotherapist Michelle McCarthy speaking on exercise and living well with Parkinson's. And then, as Joanna mentioned, we will have a 30-minute panel discussion. So if you had any questions that weren't answered, or if we ran out of time, this is your opportunity to ask them again. Or if you have any more questions, it's a great opportunity. And they will all be present at the panel question and answer period. So that concludes our webinar today. Thank you so much.
Thank you. Thanks, everyone.